The last topic I wanted to cover in the area of early stage breast cancer is managing comorbidities. You know, we have more breast cancer survivors alive now more than ever, which is a great thing, but it means that more people have some of the side effects. Menopausal side effects particularly, which really are a large constellation of side effects, certainly arise more often in our patients. Christy, any thoughts on what the best management options are for? I know this is a loaded question, a lot of information, but how do you evaluate menopausal symptoms and manage them?
Well, I think especially on the aromatase inhibitors, we're all talking about the arthralgias and myalgias, and I think we're all grasping for some magic bullet there that's going to deal with the problem. And you know, there's some suggestions that perhaps vitamin D may have an effect, but all of these effects seem to be very modest when looked at in placebo-based sort of situations. I think, you know, there are probably a lot more morbidities that maybe we don't necessarily discuss as often as we should, and one of those is urogenital atrophy and vaginal dryness. And we're very challenged to know the safety of using vaginal estrogen preparations, either with the Estring or the Vagifem tablets, and there's a lot of stuff that's going on out there. There have been attempts at doing serum levels of estrogen in women on these products with varying amount of evidence that they are coming through systemically. So I think in many ways, if you can get them through the arthralgias, that's a big problem for the patients. It's either that issue, or with tamoxifen, it's the hot flashes, and you kind of pick your poison as to what the discussions are at this point.
You know, I was looking through the San Antonio abstract book, and I saw a abstract by Sherry Goldfarb looking specifically at the estradiol levels with Estring and Vagifem, and that it doesn't increase it when patients are given concomitant aromatase inhibitor use. So,
and I think that was shown before already.
Well, with tamoxifen for sure, and I know with the AIs, you know, in a small study of 10 patients, it wasn't really, you know, there was a suggestion that they might actually be elevated, but this was an abstract which, you know, certainly made me feel better about giving the patients Vagifem and Estring. So.
Mm-hmm.
Also, the other common feature that we see in a lot of our patients is obesity, and to some extent diabetes as well. There is some data that's emerging on the outcomes of patients that have elevated body mass index and maybe differential impacts of hormonal therapy. Bill, what's the latest that we know about in terms of outcomes in the context of hormonal therapy?
Yeah, well, certainly obesity is, you know, just generally a public health horrible problem in the United States, and it's escalating with each passing year, and the fraction of patients that are obese in our population is increasing. How it impacts on disease in general is pretty clear. It's a bad thing. Breast cancer specifically, it has an impact clinically because we make decisions often underdosing chemotherapy because we think that we're going to be conferring too much toxicity, which is probably done in error. We have data from endocrine adjuvant trials that the impact of therapy may be lessened if you have a body mass index that's significantly elevated. And we know epidemiologically as well that the outcome may be worse in these patients. So there's a number of things that sort of all point in the same direction, that being overweight is not a good thing from a number of different reasons. Disease incidence, how you do once you have the disease, and how clinicians make decisions regarding therapy based on your weight, which may be you know, a function of the clinicians not understanding proper dosing.
One of the things that we're lacking, however, are data that if women start out obese with their diagnosis or with their therapy, that their outcome is changed by losing weight and coming under normal body weight. And so it's difficult to know. You would presume and hope that that would be true. We know the opposite is true, that if you gain weight after a diagnosis, you have a worse outcome. If you lose weight, we don't know. And I think what will be interesting, although this trial is still ongoing, is the Metformin trial, looking at different pathways other than just conversion of estrogen peripherally. You know, maybe these are not estrogen issues. Maybe a lot of these have to do with glucose metabolism. And so we'll see.
There's been some data suggesting that perhaps aromatase inhibitors might get overwhelmed in patients with high body mass indices. Are any of you actually using tamoxifen in postmenopausal patients based on body mass?
Well, I do use tamoxifen based on body mass. I do use tamoxifen, but not because based on body mass. I mean, sometimes they'll beg me not to give them tamoxifen because they think they will gain more weight because, you know, they've had breast cancer, they want to lose weight. But I still use tamoxifen, and I think it's variable, the weight issues surrounding it.
You know what, speaking about that, because there certainly is a perception that tamoxifen causes weight gain, but if you go to the P1 prevention trial, there is no difference in weight, and everybody gains weight.
I know.
Exactly right.
Yeah, I do mention that to them. And with that being said, I have had patients who have lost massive amounts of weight on tamoxifen, 80 pounds. I had one lady in particular.
Presumably she's eating less.
She did. She went on a diet.
Yeah,
She
there
was
you go.
pretty chubby, but she did a great job.